Hello, this is Michelle Bonson, and I'm a clinical quality consultant at the Iowa Healthcare Collaborative. Thank you for joining me to learn about this very important and pertinent topic, the opioid crisis. I think it goes without saying that nearly every day there is a news story, an article, or some other piece of information regarding opioids, and thus the term crisis is quite fitting. I would venture to guess that each one of you has or will encounter situations involving misuse or abuse of opioids, whether it is associated with patient care or within your social circles. The goal for today's discussion are to provide you with an overview of the opioid epidemic nationally and in Iowa, review opioid medication information, review legislation and professional standards and statements, and discuss strategies and tools to address the opioid crisis. I think it's important to prompt an audience with questions prior to a presentation so that they have some key things to think about. This aids in equating what you hear to what actions you might take. It enhances learning, and let's not kid ourselves, it helps with focus and attention. So here are three things I would like you to think about as we delve into the material. What actions can nurses take in the upstream movement to address opioid use? What strategies are your organizations currently using to combat the opioid crisis? And finally, what is one thing you learned from today that you can share with those in your unit or organization? Let's start by talking a little bit about the opioid crisis in the United States. The opioid crisis, in essence, was born out of the healthcare system. While all the points on this slide are important from a historical perspective, I would like to emphasize that the actual marketing and expansion of the use of opioids began in the 90s, followed by an emphasis on pain as the fifth vital sign in the 2000s, which caused an explosion, if you will, of overprescribing, misuse, and then trying to figure out how to counteract the problem with the development of deterrent medications. Drug overdose is the leading cause of accidental death in the United States. Opioids account for more than half of the overdose deaths. Data from 2015 demonstrates that an alarming number of people were using prescription pain medications without any clinical indication, and if indicated, misusing them. 80% of new heroin users start by misusing prescription painkillers. This slide, albeit just a sliver of the plethora of statistics available, paints a very concerning picture that has ultimately resulted in national and local attention. We'll talk a little bit more about that later in this presentation. These data show how the trending of opioid-related deaths, and as you can see, other synthetic opioids surpassed heroin and commonly prescribed opioids mid-2015 to 2016. Other synthetic opioids are sometimes referred to as fentanyl or tramadol. A few slides back, we discussed how 80% of heroin users started by misusing painkillers. This infographic serves as a great visual to how that may happen from a financial standpoint. As you can see, the street value of various prescription drugs compared to a bag of heroin. For reference, one bag of heroin equals one dose. The Minnesota Department of Health has a great opioid dashboard, which provides language of substance use disorder, including street language for drugs, combinations of drugs, quantities of opioids, and other street language that describes activities related to misuse of drugs. I found it extremely interesting and can see where the information would be helpful when conversing with patients, families, law enforcement, and maybe even in your general social circles. By way of reference, all the words in this pictograph represent different street names for the various types of opioids. There is a link at the bottom of this slide that can take you directly to that Minnesota Department of Health opioid dashboard where you can gain additional information. Let's move into the impact of opioids within the confines of our state. This map provides great perspective on the number of opioid prescriptions per 100 people per county in Iowa in 2016. The southernmost counties had nearly, if not at least, one prescription per person. Given that not everyone is prescribed an opioid, we could gather from this that many people have more than one prescription for opioids. These maps provide a little different view and range per 100 persons. As you can see, there has been great improvement since 2013. However, what it doesn't tell us is how many persons have moved from prescription to non-prescription methods of opioid misuse and abuse. I anticipate an opportunity to learn more about prescribing and misuse as legislative changes and increased focus are placed on combating the crisis. Opioid-related hospitalizations continue to increase, with most attributed to females, those 65 years or older, persons living in a metropolitan area, and those of lower income. Of interest to me was an additional factor related to the crisis, which is lost workers. And in Iowa in 2015, 13,500 men and 17,400 women were absent from the labor force due to opioids. I think this helps us think about things outside of the healthcare field and how it does impact persons' lives, their well being, and as well as the places where they are employed. While there was a dip in opioid-related overdose deaths in 2014, the trend continues to climb, but at a much smaller rate and volume when compared to national data. These data in the bottom graph are strikingly similar to the United States data we reviewed earlier. Prescription opioid overdose deaths are trending downward, while synthetic opioid overdose deaths are trending upward. There is good news, however. According to preliminary data from the Iowa Department of Public Health, the number of deaths involving opioids from January to August of 2018 had fallen 35% when compared to the same time period in 2017. So, 89 opioid-related deaths occurred during that first 8 months of 2018 compared to 137 in 2017. There are multiple reasons cited, and my assumption would be that a more robust report encompassing all of 2018 data will be forthcoming in 2019. We've reviewed history, data, and before we move into legislation, strategies, and tools, let's take a moment to briefly review opioids, sort of an opioid 101. Opioids are natural or synthetic chemicals that reduce feelings of pain. Some common prescription opioids are codeine, OxyContin, Vicodin, Dilaudid, and others that are seen here on the slide. There are indications for opioids. It's important not to lose sight of that. What is equally important is the decision-making process for starting an opioid versus non-opioid treatment, and if started, starting low, slow, and with a tapering plan in place. The side effects of opioids vary in degree of severity and may mimic side effects of other drugs or even general illness. Please take note of the staggering number of people treated in the ED each day due to not using prescriptions as indicated. You are so very important in this equation. You can make a difference by providing accurate and timely medication education to patients, their families, and their friends. I've heard opioid withdrawal described as worse than the worst flu and possibly even worse than death. For example, death would be easier. The important thing to remember, however, is that opioid withdrawal alone is not life threatening. There are two phases to withdrawal, and with the acute phase, sometimes referred to as being dope sick, this begins about 12 hours after the last dose of opioids, and it can last anywhere from 1 to 4 weeks. There's a peak around 3 to 5 days, and people are mostly having physical symptoms at this time. The post-acute withdrawal, which is the longer period of time, can last up to 2 years. The brain requires time to heal and reconfigure, if you will, to what it was prior to dependence, and most people are experiencing emotional symptoms during this time. This slide has various signs and symptoms related to opioid overdose. I'm sure you're very aware of these, but are your patients, are their friends, are their families? I highly encourage you to talk openly and honestly about warning signs, the importance of seeking emergency medical care, and reversal agents, which is a great segue into our next couple of slides. Naloxone is used to rescue individuals from an opioid overdose. You're probably used to using this in your clinic and or in the hospital, particularly Narcan. It does bind to opioid receptors, which blocks and reverses the effects of the opioids. It's very fast acting. People can go from near comatose to probably even sometimes combative very quickly, and there are various formulations in which to administer this. I would suggest that you, when you're educating your patients, tell them that perhaps more than one dose is needed, and once it's given, the person should be observed and constantly for at least 2 hours by medical personnel following the last dose. It's not uncommon for somebody to need more than one dose of naloxone to combat the overdose. Some good news in Iowa. Iowa pharmacies can dispense naloxone without a prescription under a statewide standing order. There are various pharmacies throughout Iowa counties that have standing orders. A person may walk in, ask for naloxone, and leave with it. It's as simple as that. Let's get into legislation and professional standards and statements. There was some recent Iowa legislation in May of 2018. Governor Kim Reynolds signed a new bill into law. It was known as the Opioid Bill, and it significantly changed the landscape of Iowa's efforts to combat the opioid epidemic. I would draw your attention to the chart in this slide, particularly the green check marks that are in parentheses. It indicates changes due to past legislation. The Prescription Monitoring Program is a healthcare tool for practitioners to assist in identifying patients who might be diverting, misusing, or abusing controlled substances. It also helps practitioners access to find the most appropriate and effective medical use of these substances. The PMP is housed within the Iowa Board of Pharmacy, and just as a side note, the Iowa PMP was recently upgraded to a new platform to help with some of the changes that came through with that legislation. One of the questions you might have is, what does this have to do to me? Will I ever need to access the PMP? And the answer to that is yes, if you are an authorized delegate. A registered practitioner who is a prescriber or pharmacist may authorize up to 6 delegates, and then the delegates may have more than one registered practitioner they access the PMP for. And the role that you would serve in that would be to gather information for a provider who is caring for a patient who is either currently on opioids or they may be considered prescribing opioids for. The PMP changes specifically are that all prescribers must register for the PMP, and prior to issuing an opioid prescription, they or their designee must check the PMP. One exception to this are patients in hospice or long-term care facilities. Prescription information for any controlled substances have to be transmitted to the PMP within 1 business day, and the Iowa Board of Pharmacy is going to start issuing targeted proactive prescriber notifications addressing suspicious patient prescription activity. As far as prescribers go, there are some changes with that new legislation. Licensing boards have to have rules to discipline practitioners who are misprescribing opioids. That might be in quantities that exceed reasonable or prudent levels. Physicians, ARNPs, PAs, dentists, and podiatrists that prescribe opioids must now have ongoing continuing education regarding CDC opioid prescribing guidelines as a part of their license renewal, and this is in addition to any other requirements that are already in existence. And starting very shortly, prescribers are going to get an activity report. It's an annual based report from the Iowa Board of Pharmacy that will speak to their controlled substance prescriptions from the previous year, as well as a comparison with other prescribers of the same profession and specialty. So as you can imagine, when those come out, physicians and other practitioners that are able to prescribe are going to be able to kind of see where they compare to their peers. And I think that that will sort of help them gain better insight into what they need to do to improve their prescribing practices. And then beginning January 1st of 2020, all prescriptions, maybe I just said 2020 two times, but all prescriptions must be issued electronically. So no more paper and pen effective that date. Couple other high level changes. There's a Good Samaritan protection. This really basically ensures that a person seeking treatment or someone who's helped that person experiencing a drug related overdose really can't be arrested or prosecuted for certain violations that are related to that. I am not an attorney, so if you would like additional information or detail about that, you can get into the actual legislation. The link to that is at the bottom of this slide. And then finally, naloxone administration by first responders and doses dispensed by pharmacies are now reportable to the PMP. So the IBME, or the Iowa Board of Medical Examiners, has very strict standards around prescribing opioids or controlled substances. And we'll talk more about what the Iowa Board of Nursing states around that. But first, I thought it would be important to talk about the definition of a standard. And this comes from HG.org Legal Resources. I think it's a great overview. A standard is the established practice that is accepted as correct within that particular industry. Organizations that provide oversight often develop standards of practice in order to define the type of quality that should be provided. And I would venture to guess that each of your hospitals and or clinics have standards of practice. And it's really important that you understand those in addition to what your professional practice standards are. The Iowa Board of Medical Examiners sets forth pain management standards, while the Iowa Board of Nursing does not set forth specific standards of nursing practice as it relates to pain management or opioid use or misuse. However, I would challenge each of you to think about this wheel of standards, all of these things in the colored boxes, and why they would not fit within the care of patients with pain management challenges and or pain medication misuse. I can see where each of these would be very important during the course of care for patients that are dealing with those issues. Nurses are not immune to substance use, misuse, or mental or physical impairments. As such, the Iowa Board of Nursing offers a program aimed at maintaining a professional status while protecting the safety of the public. And I would encourage you to read about this, understand what the Iowa Board of Nursing offers, because it is important in the safety and care and treatment of patients. The Iowa Board of Nursing website has links to several opioid-related resources. It's really a nice place to launch from. As you can see, you can get to the IDPH Opioid Update newsletter, which is always filled with good information. There's a PowerPoint presentation there. You can get to the PMP through this, and then of course the nursing newsletters. The National Council of State Boards of Nursing is really responding as well. They're offering free substance use disorder CE courses. They have brochures, posters, and other resource materials that are free. And then there's also an opioid prescribing education toolkit, and it provides a direct link to various educational materials, guidelines, and toolkits developed by other professional associations, governmental organizations, and regulators. The American Nurses Association is an organization that represents the nation's 4 million RNs, and in their statement, they are committed to leading educational and advocacy efforts to address the opioid epidemic. They're going to continue to work with government agencies, the White House, some affiliates, and other stakeholders to engage RNs and APRNs in initiatives to address opioid prevention, treatment, strategy, recovery strategies. If you'd like to access anything about the ANA, I put a link in the footer as well. One of the things that the American Nurses Association put out in response to the opioid epidemic is this issue brief, and you can access it again. I try to put everything in the footer of each slide, but this really talks about pain management, legislation, substance use disorder, nursing treatment and deterrence, and education and other resources. And I would highly encourage you to read it. The ANA, the Iowa Board of Nursing, and all of our other professional groups are really trying to help us be as effective as we can be in our roles in working with patients with opioid use disorder. Diversion is a topic that is important to you, particularly as you need to know your organization's policies and procedures for reporting any suspected diversion. I Googled diversion in Iowa, and these three articles came up on Google, and I can tell you that there were many more. But as you read through these on the slide, you may be thinking, boy, that's familiar to me, or I remember hearing about this. And I think it just points to the importance of really understanding how this can happen, that no one is immune, and that you really need to understand what your role and responsibility is if you suspect someone is diverting medications. All right, we're at the fun part now, the strategies and the tools. I think it goes without saying that a person using opioids, misusing opioids, or abusing opioids doesn't really have a look per se. Any one of these people could represent one of the 21 to 29% of the population that misuse opioids prescribed to them, or one of the 8 to 12% who develop an opioid use disorder. I think Albert Einstein put it well when he said, in the middle of difficulty lies opportunity. And I think that's where we're at. It is a difficult time, but there is a lot of opportunity, and there's a lot of emphasis, and there are a lot of tools. And let's talk a little bit more about those. So there are a couple of approaches. We're going to talk about chronic pain management, and then we'll talk about acute pain management. Not one person is responsible for managing a patient with chronic pain. It really does take a team. And I would encourage you to think about how you manage diabetic patients, how you manage CHF patients, and how that would translate over to the care of a patient with chronic pain. I think you need to allocate enough time to complete the necessary evaluations and treatment plans for persons with chronic pain, and also think about the treatment that may be different. It may include behavioral, motivational, and ancillary modalities, and a few of those are listed on this slide for you. There are several risk screening tools for misuse or abuse that help with identification of patients who may not successfully manage their opioid prescription. And while those are all great and they really serve a specific purpose, I think it's important to not ignore red flags that you may discover via patient interview, past medical record review, or even looking at transfer documents. So think about those patients that are starting an opioid therapy and those that have been on opioid therapy. And you can read through a few of these on your own and kind of think about what would trigger in your mind when you're assessing risk on patients. Because I really think the nurse does have a role in this. I think that you may learn things from your patients that may not be evident to the practitioner, and I think it's important for those things to be brought to their attention. So responses to some of those red flags, some things you might need to consider is that if continued prescribing puts a patient at risk or puts the provider at risk who is prescribing, I think that they need to discontinue the prescribing immediately. That's what's recommended. Nobody wants to be at risk of violating the law. Patients rarely need to be fired from a practice. Prescribing can be discontinued while still maintaining a therapeutic and professional relationship. And then I think increased scrutiny is helpful to delineate whether a patient is presenting with substance use disorder versus other treatment issues. So there's several things listed here. I would just say that through frequent query of the PMP, which is now a legislative mandate, that's going to help with that. And I think we're already starting to see shorter duration of prescription controlled substances. It used to be that you'd leave the hospital with 30 days of a pain medication, or have a dental procedure, and you'd leave with a much more than you needed. But those days are leaving us. And then also the addition of pain contracts, which is not necessarily a legal binding agreement between a practitioner and their patient. It's really an accountability agreement regarding proper use of their medications and management of their pain. Acute pain management is a little bit different. I think it's important to consider non-pharmacological options. You really should use minimum dosing of pain medication if it's needed, and then maximum education. I think it's important to discuss realistic comfort, functionality goals at each touch point, and then use comfort resources. Use a comfort scale, a comfort menu, and a treatment plan when working with patients who are dealing with pain management issues. So some non-pharmacological options, there are physical strategies and there are cognitive mental strategies. I would point out that aromatherapy is starting to be utilized in hospitals. Some are finding that to be very helpful, and they have policies around that. And then I would suggest that meditation, guided imagery, pet therapy is a great thing. Those are things that can help people dealing with pain. They also help with anxiety. I don't know if any of you have been traveling recently, but there are pets in airports now, and it's absolutely fantastic. So I think there's a lot of opportunity here. When patients are experiencing pain and they're being prescribed opioids, I think there's a few things that we need to be cognizant of. And I think we need to be very candid with our patients when we're educating them. I think they need to know that they may never be pain free. And that's really applicable to patients with chronic pain. They might be expecting to feel zero pain, and that might not be realistic. And I think we need to understand their comfort levels and their tolerability of pain. And then when they are prescribed something, we want them to have the minimal side effects. And so those are conversations we have with patients. That's how we partner with them. And I think it's important to understand how they want to be able to function. Is it important for them to be able to do their daily tasks and get through the day? Or are they wanting to do things that they were doing before? Maybe perhaps they were heavy exercisers and they enjoyed that, but maybe light exercise is the right thing. So it's really connecting with them on what's important to them and how they want to manage their pain. A comfort scale is different than a pain scale. As you can see on this slide, there are faces and colors, and this really helps people identify how they're feeling in a different way. So rather than saying my pain is a 10, they might say, I'm feeling pretty uncomfortable right now. And this can be used for persons who have varying degree of intellect. It can be used for children who aren't able to read. And I just like that the colors emphasize those things. You've got the really red, angry, upset, and you've got the green and happy. So it's just a different way of thinking about things. And this is very complementary to the next couple of slides that we're going to go over. A comfort menu is a menu, if you will, that is similar to a dietary menu. So when a patient is in the hospital, they take ownership of this and they choose things that help them feel more comfortable and manage their pain. And so it helps them design a treatment plan. And I say they because they need to be an active participant in their care. And you can read through this on your own, but it's really about what is going to help them. Here are some key things that they feel are helpful to them in managing their pain. So there is one for the inpatient, and then there's one for the outpatient. And this is really thinking about when they are at home. So that's a little bit different. And you could read through those and see the differences. But again, they all address comfort, personal care, comfort actions, relaxation, and medication. I would like to point out that these are developed in conjunction with Broadlawns Medical Center. They worked with us in developing these comfort menus and wanted to just give them a shout out because I think they found them to be very helpful, and I know several of our other hospitals within our network have as well. A comfort treatment plan is something that can be utilized for patients for acute conditions as well as chronic conditions. I'd like to just point out a couple of differences. One is around the goals and the time frames. So the acute obviously is going to be much shorter, and then the chronic is going to be longer. And it's utilizing that comfort scale again, and as well as pain relief options, which takes you back to those treatment plans. So you utilize those menu items or the alternative pain relieving measures to be able to build out this comfort treatment plan. And then also, it gives them education on their medications, tells them what they're taking, why they're taking it, et cetera. And then also what they need to do if they have concerns, as well as calling 911 if they're having some pretty severe side effects or potential overdose. Again, these were developed in conjunction with Broadlawns, and any clinic or health system can utilize these by inserting their logo. As we've talked about each of the tools, we've really talked a little bit about person and family engagement, and it's really about bringing the patient and their family and or friend into the equation when they're trying to develop ways to manage their pain, what they're going to do when they're transitioning from inpatient to outpatient, and it really helps them ask questions. As you can imagine, and you probably have potentially experienced this, a patient who is not able to get the services that they need or want or expect in a time frame or at the caliber that they want, they might get kind of angry. And so I think there's an elevated opportunity in light of the implementation of all these safety guidelines around chronic pain and prescription opioids, specifically when it talks about pain agreements, when you start talking about some of the regulations and you can't prescribe it the way that they were being prescribed before, and maybe you're going to discontinue or start tapering them off of their pain medication, and you start talking to them about side effects and some of the dangers of overdose. And what typically drives anger in patients is fear. The other thing is opioid medications can really become a patient's primary coping strategy for dealing with physical, emotional, psychological, and post-traumatic pain. So those medications have become their best friend. And so if you think about losing your best friend and what that would feel like, you're going to have fear, maybe some anger, you're going to have sadness and panic, you're going to grieve a little bit, and you might even think, I can't go on. These are all of the things that might be happening simultaneously in that patient's mind, or they may be happening in isolation of one another. So, how do you deal with those situations? I think it's important to remember your core values and remember why you're doing what you're doing, or remember why the physician is doing what he or she is doing. And I think that that helps ground you. And I think it's important to understand that patients might leave an office or leave a hospital angry, sad, distressed. It doesn't mean you failed. They just might need to work through the message. And when you're having a conversation, you might feel uncomfortable, and that's okay. You just need to turn yucky and yikes into I'm willing to do this and have this conversation because it aligns with my values. Your patients really value you and the healthcare team, and they want to partner with you. I always think about the 80-20 rule. Not everyone is there to be a pain or not want to partner or wants to be difficult. I think 80% of the population really cares about that relationship with the healthcare team. And it might be even higher than that, but the 80-20 rule is always something good to follow. And then the other thing is they need you to have confidence in them. So if you think about your favorite sports team, maybe it's college, maybe it's professional, but You're a cheerleader for them when your team is up and when it's down. And your patients want you to be there for them when they're up and when they're down. And you need to incorporate active collaboration to promote self-efficacy. So utilizing motivational interviewing, engaging them in their development of their plan to manage their care. Medication assisted treatment, sometimes referred to as MAT, is really taking a combined approach to treat substance use disorder and overdose. And so they utilize medications, counseling, behavioral therapies. They're really focused on the whole person, not just the use or abuse or misuse. And the programs that are MAT are subject to federal legislation, regulation, and guidelines. So it's not just something that can just pop up and happen. There are several medications to treat addiction: methadone, naltrexone, and buprenorphine. Those are things that you've probably heard of before. There are several resources available. At the IDPH site, there is a map where you can find out where MAT is provided in the state of Iowa, and you can do a search by address. So if you're interested in helping a patient find where they might be able to receive treatment or helping your providers identify that, you could go to that website. There is also a map that's put out by SAMHSA that has to do with physicians who are authorized to treat opioid dependency with buprenorphine by state. Again, easy to use. You can click on it. You can click on the surrounding states because that may be applicable depending upon where you are at in the state of Iowa. There are more than 50 community pharmacies and law enforcement centers that have permanent collection boxes where patients and or families can drop off unused medications. Also, they might drop off expired controlled medications as well as other prescription and over-the-counter medications. Basically, I would think about patients who are perhaps elderly in particular, and I don't intend to pick on that population. Please know that I have parents in that age group, and sometimes they like to put stuff in their medicine cabinet for a rainy day. And what happens is if that rainy day medication is obtained by maybe a younger person in their family, maybe a grandchild, or somebody in the neighborhood knows that it's there, they might break in to get it if they're really, really craving and needing that opioid. So I think it's important to educate your patients on this. And as you can see by this map, it's pretty easy to follow. There's a little prescription bottle, and those are the pharmacies, and then there's a little badge, and those are the law enforcement agencies where you can drop off medications. Tools, tools, and more tools. Awareness creates interest, interest creates excitement, excitement creates energy, and energy creates action and a plethora of tools. That's the title of this slide. So I wanted to provide you with some reputable resources that I think are good for you to utilize as you do research or you're looking for information. CMS would be one, CDC is another, SAMHSA, the Iowa Department of Public Health, and then a shameless plug for my organization, the Iowa Healthcare Collaborative. We do offer a lot of tools and services to the hospitals and clinics that participate in, and as well as the communities who participate in our programs. As we finish out, I'm going to circle back to those questions that we started with at the beginning of this presentation. And what I'd ask you to jot a few things down. What actions do you think nurses can take in the upstream movement to address opioid use? What strategies are your organizations currently using to combat the opioid crisis? And perhaps you know this, and if you don't know, maybe this presentation will help you formulate your question for your organization so you can find out more information. And what is one thing you learned from today that you can share with those in your unit or organization? I would hope that you learned something, tidbit of information that you can take away, and hope you enjoyed learning more about this opioid crisis that we are in. Thank you very much for your time. Thank you for joining me. My name is Michelle Bonson. I can be reached via email. It's on the slide here. I would encourage you to reach out with any questions or comments that you have, and I would be happy to assist you. Thank you.